And then it also has connective tissue diseases. And last, skin, okay, our dermatology. So it has three things, and there are three doctors, usually they are involved of MSK. One is dermatologist because they involve with the skin, and then orthopedic surgeon who involves with the bone, okay? Now, third doctors are rheumatologists, okay? That's why we actually call MSK for step 1. When you go to step 2, it's become rheumatology. Is that clear, folks? So that's rheumatology. So who are rheumatologists? These are the doctors, mostly they work on the joint disorder and connective tissue diseases, folks, okay? Especially autoimmune diseases. Those are the one, that's rheumatologist, okay? So that's why if you see, anytime you go to a clinic, rheumatologist, orthopedic surgeon, and dermatologist, they're always in one clinic because they all share patients. Is that clear, folks? Okay. So that's the big picture of MSK. Now, first, we're going to focus on bone and joint. Okay. First, we're going to start with bone and joint. In that, bone is pure anatomy, but I'm going to focus first on the joint diseases. These are called system diseases, okay, systemic diseases. Once we're done with the system, joints, connective tissue, then we will come to the bone, because bone is a pure anatomy. There's nothing to understand. It's a memorization, okay? So I want you guys to go page 466 to start with some basics, and then we're going to finish all the systemic diseases, which is considered high yield. All right. Now, when we talk about bones, there's a two terminology comes, folks: endochondral ossification, membranous ossifications. Okay, these are the two terminology we need to get used to it. Let's talk about this. Now, when a fetus is developed, okay, there are some bones where they are first cartilage, then they are replaced to bone afterward. Okay, so they were first cartilage and then they become bone afterward. Is that clear, folks? That is called endochondral ossifications. Okay, I'm just going to say that. If I tell you endochondral ossification, these were cartilage first, and then eventually osteoblast and osteoclast comes and replace to bone. Now I'll give a good example. When you hold a newborn baby, right? Now, when the newborn baby's hand, you see right now we have two bones, ulnar and radius, isn't it, folks? Newborn, these are cartilage. The bone is just a cartilage. That's why you could easily bend. I mean, you can't bend 40 degrees, but you could bend it almost, folks, okay? Because why you are able to bend? They are still cartilage. Is everybody clear, folks? And then after a couple of months, by 6 months completes, all those cartilage becomes a full of bones. Is everybody clear, folks? These are called endochondral ossifications. That's important. Now you could see that here. These are cartilaginous model of bone is first made by chondrocytes. Chondrocytes are the cells that makes the cartilage. Then osteoclast and osteoblast later replace the bone and then remodel to lamellar bone. You see how it becomes and changes. Is everybody clear, folks? 90% of the bones in your body is endochondral ossifications. All the long bones and everything, they were cartilage and then it changed to a bone. Okay, forget about the diseases, folks. Okay, don't pay attention to diseases now. Let's learn the terminal physiology first. So now everybody knows what's endochondral ossification. So they were cartilage and then become. There are some other part of the body where from the day one, they were bones. They were bones. So they never been a cartilage. Is that clear, folks? That is called membranous ossification. So when I say membranous ossification, those particular bones never were cartilage. They were just bone from the day one. They were bone from the day one. Is everybody clear, folks? Now let's see what are those bones specifically, right? Bones of calvarium. Where's the calvarium? Show me. That's your skull bones, all these bones on the top, okay. Facial bones, what are the facial bones? You have maxillary bones, zygomatic, mandible, all of them, right? Ethmoidal, okay. And clavicle. Clavicle is the most important. Clavicle is a membranous bone. So what does that mean? They were always a bone from the day one, folks. There is no cartilage, okay. Now, few things let's discuss about it. Number one, when lady is pregnant and they are about to do normal delivery, always they measure the shoulder of the fetus, because if the baby is big, we cannot do normal delivery, because when they come through the birth canal, vaginal canal, they can fracture the clavicle because if it is wide. Is everybody clear, folks? Why we worry about it? We don't worry about the hands and legs, because hands and legs can bend and we could manipulate and pull the baby out. Okay, but we cannot do anything to clavicle, because clavicle will not bend. It's because it's a bone from the day one. Is everybody clear, folks? That's number one. Number two, when people have fracture, okay, when people have fracture, the endochondral ossification bone will heal so fast comparing to membranous ossification. Why? They kind of have a stem cells of your chondrocytes. They will help to heal it better because they have a cartilage backup. Is that clear, folks? That's why, like, for example, when somebody break their arm, all you have to do is put a cast. Within 2-3 weeks, it will attach back. Is everybody clear, folks? But when somebody has a fracture of clavicle or facial bone, that takes months and months to heal. That takes months and months to heal, folks. Why? They don't have a cartilage support or chondrocyte supports. They've been a bone from the day one, so it always takes a longer time to heal. Is everybody clear? All right. So these are the two bone formations. So 90% of our human bones are endochondral ossification, but we have the 10% that's membranous ossification. In my opinion, I would remember only those 3 bones, because we know everything else is endochondral ossification. Is that clear, folks? There are diseases, we're going to talk about it. Some disease affect endochondral ossification, some disease affect membranous ossification. Is everybody clear?
The chondrocytes work on making the cartilage or in converting to
see, they only work making the cartilage.
Okay.
Chondrocytes are the cells of cartilage. Okay, that's the idea, folks. Now, once we get this, now let's go to this page. You know, this is a repeating from endocrine. We already know what is osteoblast and osteoclast. We already know how parathyroid hormone works. The only thing we have not talked about too much is estrogen. Okay. Now I'm going to make it simple. I'm going to break down this 3 line in one simple form, folks, okay? Estrogen stimulates osteoblast. Estrogen stimulates osteoblast and kind of inhibits osteoclast. So that means more estrogen, more bone formation. Is that clear, folks? And they wrote it in a long sentence. Look at that. Estrogen inhibits apoptosis in bone-forming osteoblasts. So they're inhibiting the apoptosis of osteoblasts. So technically, they are stimulating or making more osteoblast available. Is that clear, folks? I just took this 3 line and put it in 2.4. That's all it is. So as long as a female produces estrogen, they have a good bones. Is that clear? Clear, folks? When the person has menopause, no estrogen. If there is no estrogen, no osteoblasts, only osteoclast. So they are breaking down the bone, so the bone becomes weak. That's why menopause females can easily have fractures. Is that clear, folks? All right, that's all. What's the other disease they lose estrogen? Premature ovarian failure would have been the same thing. Okay, just to remember that, folks. So that's about estrogen. Any questions so far? All right. Not these are all bones, so I'm gonna go get to the disease first. Systemic diseases. We'll come to all these diseases. We're gonna do it, but we're gonna start here. Go to page 472. We're gonna start from here first. Finish all the joint diseases, rheumatologies. Now, first disease, achondroplasia. The problem with achondroplasia, failure of longitudinal bone growth, which is affecting endochondrial ossification. So these people have a defected endochondrial ossification, which means their skull, bone, clavicle is normal, everything else did not develop. Is that clear, folks? So they have a short upper extremity and short lower extremity. You could see that. Membranous ossification is not affected. I found some first aid book says is affected. There's a printing mistake. They didn't put the note word, so pay attention, okay? Membranous ossification is not affected. So when you look at these patients, it looks like they have a big head to their extremities, but actually the head is the same size. Because of the extremities are short, it looks like that. Is that clear, folks? Yeah. Now, these are due to constitution. Inhibits chondrocyte. Look at that. They inhibited chondrocytes. They never developed proper cartilage. And we know endochondrial ossification, you need to develop cartilage first before you get to the bone. Is that clear, folks? Okay. More than 85% of the mutation occurs sporadically. And with the autosomal dominant full penetrance, what is full penetrance? If you have the gene, you get the disease. That's it. There is no escape. Okay. It's lethal. Associated with paternal age and stuff, most common cause of short limb dwarfism. That's basically it is, folks. Okay, these people have a short extremity, but the head and body is just normal. So that's achondroplasia. You see, when you know what is endochondrial and membranous ossification, the disease is nothing. It's simple disease, folks. Okay, so that's that. Next, osteoporosis. Osteoporosis. The problem is the bone mineralization is affected. Okay, even though they have a normal bone mineralization, look at here, cortical bone loss mass despite normal mineralization. That's the idea. Because they have a normal bone mineralization, their calcium level is normal. That's very important. If you remember this chart, remember this XY axis, we talked about it. This is calcium, this is PTH. Where did we say we put osteoporosis here? We said it's come under normal, isn't it, folks? Why do we call it normal? Because the mineralization is still normal. Only if your mineralization is affected, you will release more calcium or not. Is that clear, folks? So osteoporosis people have normal serum calcium. Get that first. Okay. Okay. Now, most commonly due to increased bone resorption, osteoclast number and activity related to decreased estrogen level old age. That's a key here. We just talked about it. Some medication can also do that, like a steroid. It basically, your bone is becoming weak. That's all it is. Okay.
Doctor, can you explain what exactly is bone mineralization?
Mineralization means the quality of the bone is still, like, how do I put it? Let's say mineralization, let's say the bone has to break and build, break and build. That is happening here. That's not a problem here. But the problem is decreased estrogen. The quality of osteoblast is kind of low here. So that means they are breaking and building, but when the building quality is not good. So there is cells to build the bone, but the quality is not good. So put it in this way, because you have osteoblast, what is the function of osteoblast? You build the bone, isn't it? And then osteoclasts break. That building and break is called normal mineralization. But here they are doing it, but not in a proper quality. So that means the bone is still getting built, but it's kind of weak, easy to break. Put it in that way. Okay, so that's the idea here. Now, all the other diseases, you could see that here, mostly is what is a steroid and menopause. That should come to your mind. Key to diagnose, we do DEXA scan, folks. Okay, now, which doctor diagnosed osteoporosis? Yes. So there's something called T-score. Okay. T-score is basically measuring the thickness of the bone. Okay. When people come and if you suspect they have osteoporosis, we will do a DEXA scan. Where do you scan it? You scan the femur bone and vertebral bone. These are the two bones you scan. The femur of your thigh and the vertebral bone of your back. These are the two bones that we scan, no other bones. We scan those two bones and we measure the thickness of the bone. Healthy people should be in the positive. This is healthy. Healthy people should be in the positive thickness. Okay. Now, if people have problem with the bone thickness or the quality, it will go into negative, folks. Up to minus 2.5, we call osteopenia. More than minus 2.5, we call osteoporosis. That's called osteoporosis, which means when we measure the bone thickness, is going in negative. Is that clear, folks? So when do you tell patient has osteoporosis? When their bone scan comes with more than minus 2.5. So it has to be like 2.7, 2.9 minus. Is that clear, folks? Okay. What if you get minus 1.5? That's osteopenia. What is osteopenia? It's like a precursor to osteoporosis. When people is in osteopenia, if you do an aggressive treatment, you could keep them. If you don't treat it, they will eventually get into osteoporosis. Is that clear, folks? So who does this? Radiologist, okay? T-score is a measurement. All the radiologist is the one that who diagnose osteoporosis. It's basically measuring the thickness of the bone, okay, folks? That's the idea. I'll come to the question, Arslan, you asked 1 second. So now if you see here, folks, you see T-score of more negative than 2.5 is the key for it. So now you guys know what is that. So that's why we take 2 samples. What if I tell you I have a patient's femur bone that shows minus 2.7 and vertebral bone minus 1.5? So do you diagnose this patient with osteopenia or osteoporosis? You go for the worst one, okay? You take the more negative one, so you diagnose the patient with osteoporosis, folks, okay? So that's that. Now, one-time screening recommended in females more than 65-year-old because that's where the estrogen come to play. That's very important, folks, okay? Now, how do you prevent these things? Prophylaxis. Regular weight-bearing exercise. See, when people have osteoporosis, we tell them to do weightlifting, not cardio, weightlifting. What weightlifting does? It develops their muscles. Muscles will protect their bone. Does that make sense, folks? People have to understand, by weightlifting, they are not bringing anything back to the bone. Bone is going to be the same, but what's the function of muscle? Muscle protect the bone and joint, isn't it, folks? If you keep your muscle strong, you're not going to have a joint problem or fractures. So that's what the weightlifting, adequate amount of calcium and possible vitamin D. So that's important. If those don't work, we have to give medicine. Bisphosphonate, we call Fosamax, right? That's a famous brand here. We give that. Teriparatide, we give that, denosumab. Does that ring the bell somewhere? In immunology, we studied, right? What does denosumab do? Type it up for me. I want the mechanism of action. Type it. I'm waiting for it. It bind where? Let's see. It inhibit rank L, isn't it, folks? It inhibit rank L. Okay, so when they inhibit rank L, they cannot go bind to osteoclast and activates it. Now it should make sense why we use that for these people. Okay, that's there. So because osteoporosis people, we do not want to activate osteoclast. Already they have osteoclast activation. In another word, you don't want to increase it. Is that clear, folks? All right. Now, the most common symptoms they come with vertebral compression fracture. Because of the vertebral bone becomes weak and weak. So what is the first symptom? Some people feel pain. Some people who has a very good tolerance to pain, they won't feel the pain. They come with loss of height. All of a sudden they will say that they lost half an inch of their height. Okay, so that's because of the compression fracture, folks. It can give kyphosis. Kyphosis is bending forward. Lordosis is going backward. Pregnant ladies become lordosis because they try to balance the belly, so they have to go back. So that's lordosis, folks. Okay. Now, and then you could get other fractures, but that osteoporosis, folks. Is that clear? That's osteoporosis. Okay. Now, one of the questions I was asked, what's the difference between normal bone mineralization and bone resorptions? Okay. Now, mineralization means, simply remember, the bone need to be given its nutrients and stuff, right? So basically you are giving enough calcium. Also, basically it's like feeding the bone to keep it. Now, whereas resorption mean breaking and building. So when you do that, that's the way of building. You need both. You need to continue breaking and building, and also you need to give enough nutrients. Is that clear, folks? So that's mineralization and resorption. Okay, so that's osteoporosis. Next disease, you have to be very careful. Look at the word osteopetrosis. Read it fast, you get a wrong diagnosis. Sounds like osteoporosis, but not. It is also called marble bone disease. Why do we call it marble bone? When you look at this, doesn't it look like that pelvic bone is so thick? It's so white color, it's like a marble bone, right? Now, when you see a white thick, what do you think? That bone is so thick, that's why it gives you such a white appearance. Does that make sense, folks? Now, let's see what's the problem here. Defective osteoclast. If you have a defective osteoclast, what happens here? You are building the bone, but you are not breaking it. Is that clear, folks? Because you need to break and build. So you keep building, so that's why the bone becomes thick. Is everybody following me? The bone is thicker, but some people think, is the bone is thick, isn't it its more strength? No, because the bone is poorly built, even though it's thick, but they are not built properly, folks. Easy to break, okay? Thickened, dense bone that are prone to fracture, okay? And you could see mutation can happen. So, or carbonic anhydrase impair, which ability to osteoclast to generate acidic environment. So what happens is overgrowth of cortical bone fills the bone marrow. So which means if you think this is the bone, okay, I just want you to think this is the bone thickness, and in the middle you have a marrow. Everybody knows that. Now, when this bone started to become thick, it's going to fill the space, and now bone marrow becomes smaller because they don't have enough space to build the bones. I mean, the blood cells, patient has pancytopenia. So the bone marrow is not keeping up with enough blood cell production. Is everybody clear, folks? If the bone doesn't do, who else do that? Liver and spleen. That's what we call extramedullary hematopoiesis. We studied in hematology, isn't it, folks? Anytime your bone marrow fails, your liver and spleen try to compensate for it. It can result in cranial nerve impingement and stuff, because why? The bone, all the foramina is getting thicker. Who gives osteoclasts? How do you get osteoclasts? Don't look at the book, try to recall. Which cell produces osteoclast? I taught you this when I taught hematology, folks. Come on. Not macrophage. It's actually monocytes. Somebody can argue with me, isn't it macrophage from monocyte? Well, macrophage, when they go to interstitium, then we call it macrophage. Monocyte become macrophage. Monocytes gives osteoclast. So if I tell you this particular disease is osteoclast defect, which means I'm technically telling we need a new monocytes. Is that clear, folks? So what do you think the treatment for this particular disease? Bone marrow transplant, because we need a new monocytes. You see that, folks? That's why. If you don't know where that comes from, people get suspense. Why bone marrow transplant for this? It's because monocytes gives rise to osteoclast. Have a clear here, folks? All right.
So, sorry, I had one thing. So basically, the osteoporosis, there's nothing wrong with the osteoclast and osteoblast.
No.
It's just that they're not as good as they're supposed to be. That's what
The
you're
quality is
saying,
not
right?
good. Yeah, yeah.
But there's nothing wrong with binding, or there's nothing
No.
wrong with the functions or anything like that, right? Okay.
Okay. Now,
So for osteopetrosis, this is an example of mineralization issue.
yeah, that's basically you had a defected osteoclast, so you cannot break it down. So what happened to blood calcium level? It's still normal because it cannot go down because you have to have osteoclast to break it down. Okay, so careful. Now next we're gonna go to osteitis deformans. Another name for it, Paget disease of the bone. A lot of my students are telling in the exam, they had a question. They were like, I'm sure it's Paget disease, but I didn't have an option. If you didn't have an option of Paget disease, the answer is osteitis deformans. That's a new name for it. A lot of them don't know that. Okay. So that's Paget's disease of the bone. Okay. Now let's see what is the Paget's disease, folks. Okay. Before we even talk about it, let's understand this. There's about 3 phases, right? So here what happens, imbalance between osteoblast and clast. So the normal function, what did we say? Blast build the bone and clast break it down, and then blast build. So they work nicely and they have a good understanding. But when it comes to Paget's bone, they don't have a good balance between both of them. Okay, so that's why we call it imbalance between osteoclast and osteoblast. Okay, there's no communication. Look at that. They have an early phase. The osteoclast comes and break it down so much. So they break too much than what they are supposed to. Then they have intermediate phase where osteoclast and osteoblast is there, but they are imbalanced. So forget about this one. Let's erase this now. Osteoclast comes and break it down too much. Then what happens? Osteoblast will come and build it too much to compensate that. So they are imbalanced between breaking and building, so the bone is not properly made. Is everybody clear, folks? The bone is not properly made. I'm sure the word is going to be there. Now, if you see here, it's common localized disorder of the bone remodeling caused by increased osteoclastic activity followed by increased osteoblastic activity that forms poor quality of the bone, folks. Okay. So to make it simply one line, it's imbalance between blast and blast. Are we clear, folks? Now, serum calcium and PTH, everything is normal here. We remember that when I told you on endocrine osteoporosis and Paget disease, they both have normal serum calcium level here, folks. Okay, so because why? They are just too much breakdown and build up, but it's within the bone. They are not changing anything in the serum. Okay, so one breaks it more, the other one builds it more. So the bone becomes quality. Now the word mosaic pattern of the bone, right? So what does that mean? They are not building the bone properly. It's some irregular shape and stuff. That's what we call mosaic pattern. Okay. Now somebody had some question.
I just wanted to know why you put the line through intermediate.
Oh no, so because to make it easy to understand that, see, what I was telling is first you have osteoclast breaks it down, and then osteoblast comes and try to overbreak. And in the middle, there is a phase where they both do it. That's why I kind of took it out to understand, but you could keep it there. So it's like 3 phases. One breaks it down, and then they try to work, and then the other one overbuild it. That's how it is. Okay. So that's that. These people have long bone chopstick fractures, increased blood flow from AV shunt. We talked about AV fistula. Whenever you have AV fistula, what happens to preload? Preload is super high. When the preload is super high, your heart works so much to keep up with it. What we call high output. Eventually, that heart fails, right? We talked about pre-disease. Any disease that has AV fistula should have high heart failure. Okay, and that increases risk of osteosarcoma. Symptoms: diabetes due to skull thickening, hearing loss, all these things are there. So they become mental health. So that's osteitis deformans. Okay, next one. Avascular necrosis of the bone. Yes.
Sorry, could you discuss what we're seeing in the X-ray image?
In this X-ray, the bones, if you see the pattern, let's say, increased skull thickening. You see the skull, it has become more thick. That's all you see. And also you could see it doesn't look like a straight line, it's irregular shape. You see that? That's why, because the breakdown and welding is not happening properly. So that's what it is. So thickening and irregular shape. That's all. Now, when we talk about avascular necrosis of the bone, there is only two bones in the body that's prone for avascular necrosis. What's the word avascular? No blood, because of that ischemia and necrosis. The two bones that you remember. One is head of the femur, right there. Number two. What's this bone? Same bone, if I need to do my anatomical stuff, it touches it. What is that? Anybody else see bones? The AP collarbones? Scaphoid. Okay. Scaphoid and head of the femur is known to be why they both have very low blood flow, even in healthy people. So easy to describe. Now let's look at this one. Now you can see this is the head of the femur. Okay. Now the head of the femur gets blood supply. One from this tiny blood vessel we call has to be a branch from obturator artery. Okay. Because why? This is also acicular branch. It comes from the acicular branch. The second one, medial circumflex artery. Now look at this. The medial circumflex gives such a good collapse of circulation, isn't it, folks? Now what happens is, this is what we call surgical neck of the femur. Anytime you have a fracture, surgical neck, it will destroy medial circumflex from our artery. That's okay, folks. So if medial circumflex artery gets destroyed, you think we could keep up the blood oxygen to the head of your femur? It cannot. So the head of the femur dies because this is artery branch of obturator. Such a tiny artery, it gives you severe blood. I want to show you that artery in real picture. Let's see if I can get a good picture. Here you go. Let's take a look. You guys see this picture? Now look at this. This is the head of your femur. This is the ligament. Do you see a tiny dot in the middle of the ligament? That tiny dot is that artery. So which means they are hardly bringing some blood to this area. Exactly, folks. What is this ligament called? Ligamentum capitis femoris, or capital femoral ligament. Okay. So that ligament is the one that holding the blood vessel in the middle. So very clear, folks. Anything happens to the ligament will cut down the blood supply. Clear? So that's capital femoris, folks. Okay. Now let's see here. That's our schematic diagram. That's a ligament that comes and it goes to the head. Okay, clear, folks. very tiny practical picture, folks. Okay, it's barely you can see here. All right. So now you know the medial circumflex is the one that has to give the majority of the blood. Okay, lateral, medial. That's important. Not lateral, is medial. Okay. Now let you look. It's an infarction of bone and marrow, usually very painful. Most of the site is femoral head. Causes include steroid, chronic alcohol use, sickle cell disease. Why? The cell can be sickled and block their blood vessels. Okay. Now, trauma, SLE, and some congenital problem, we'll talk about it. Remember this disease. What is Gaucher's disease? That is the most common lysosomal storage disease. And we said the unique feature for Gaucher's is avascular necrosis, isn't it? There you go, folks. And we'll talk about this leg calper disease and slip capitis. Those are two diseases that happens in newborns. We'll talk about that. Not newborn, but pediatrics. We'll talk about that. But that's here, avascular necrosis. Is that very clear, folks? All right. What's the treatment, by the way, for avascular necrosis? So that's where the problem is. So if this bone dies, what happens? Technically speaking, hip replacement or head of the femur. It's going to be a big surgery, massive surgery, folks. Okay, that's the only way, because why? Necrosis is irreversible. Once it's dead, it's dead. Okay, all right. So that's avascular necrosis of the bone, folks. Okay. Now, this is a tumor outcome. Let's continue with the diseases. Next one is the most important of rheumatology. How do we learn osteoarthritis and rheumatoid arthritis? We're going to have a massive number of questions in this, folks. When I see this picture, it looks like an inflammatory bowel disease, isn't it, folks? How they had the chart for Crohn's and ulcerative colitis, right? Same thing. We're going to learn osteoarthritis and rheumatoid arthritis. We have to know it in and out on that. Let's take a look here. Osteoarthritis, even though it's ending as itis, it is a non-inflammatory disease. It's a wear and tear. It's a wear and tear. So what's the function of cartilage? Let me get this for example. Let's assume this is one bone and this pad in the middle. So between two bones, I have the cartilage in the middle. So that's to reduce the surface friction and shock. Does that make sense, folks? So the more I use, this cartilage will get destroyed. So that's a wear and tear. So which joint you think the most commonly? Knee joint. Because all our body weight goes to the knee joint, isn't it, folks? All right, okay. So it's a mechanical wear and tear, destroy articular cartilage. Inflammation with inadequate repair, which means no inflammation, okay. Very important. Predisposing factor. Age, female, obesity, because obesity means more weight goes to the more joint, folks. Okay, that's one. Now, so that's that. Pain in weight-bearing joint after use. So people with osteoarthritis, they will complain at the end of the day, not in the beginning of the day. Because in the beginning, they feel good. By end of the day, they use so much and they complain of pain, okay? Improving with rest. Sounds like stable angina, isn't it? All right. Asymmetrical, highlight that word. Osteoarthritis is always asymmetrical. You might ask, my grandma had both knee involved, which means she did not develop at the same time. She developed one first and then the other one, okay? It's always asymmetrical. And even you guys, right? You will develop osteoarthritis first on your dominant leg. How do you know? Every human has a dominant side, isn't it, folks? Don't go with the brain. Which leg is dominant? How do you know? You look at your shoe and you will see one side has a mechanical wear and tear more than the other side, isn't it, folks? That's a side is your dominant, okay? Knee cartilage loss begins medially because the medial part has a decreased surface area, so it's easy to damage. No systemic symptoms. It is not a systemic disease, okay? It is not a systemic disease. So that's osteoarthritis so far. Is everybody clear, folks? Now, there is a bone spur. Why? Imagine now I don't have a cartilage. So what do we call this? Bone and bone. Does that make sense, folks? So when you have a bone on bone, what happens here? First, this is my bone. I had a cartilage in the middle. Now the cartilage is gone, so the space is narrowed. So the joint narrow. Now the bone is on bone. It's going to start shaving the bone and bone spur will happen. That's what we call bone spur. Joint space narrowing. Look at that. That's what you see on X-ray. But if you take the sample of the synovial fluid, it is non-inflammatory. Look at that. Non-inflammatory, less than 2000. You see, I draw this chart to kind of help you guys. It's useful if you want to copy that. Okay. This is less than 2000 synovial fluid. WBC, 2000 to 25,000. This is more than 50,000. Okay, just to remember that, folks. This is a synovial WBC, not the blood, synovial. It's a synovial fluid. So osteoarthritis, we're going to put it here. Osteoarthritis, because they are non-inflammatory. Is that clear, folks? That is non-inflammatory. Development of DIP and PIP. In my hand, which one is DIP and which one is PIP? DIP means distal, all far. This is proximal. So what is this called? MCP. Metacarpophalangeal, because it's a phalanx with a metacarpal. So this is proximal and this is distal. Is that clear, folks? All right. If you notice it, MCP is never involved. So that's easy to remember. Osteoarthritis will never involve this. Okay. Only PIP and DIP. Okay. So that's that. I'll come to the treatment in a moment. Let's go ahead and compare this with rheumatoid arthritis. Now, when you see a rheumatoid arthritis, it is an autoimmune condition. Okay, so that's a systemic disease the minute I say. It's an inflammation induces formation of pannus. What does that mean? That antibody is coming and destroying the cartilage and attacking synovial fluid. That's the idea. So that is a systemic disease. Now, female tobacco smoking, and highlight rheumatoid factor is positive. These people have rheumatoid factor, which is an IgM antibody that targets IgG of the FC region. They must ask sometimes. They do ask, what is this, folks? So you have to know it nicely, okay? So that's that. But if I ask you, what is the most specific for rheumatoid arthritis? The answer is anti-CCP. We call anti-CCP, cyclic citrullinate peptide. That is most specific. Why is that? There are 30% of the human who has rheumatoid factor in the blood, but they don't have rheumatoid arthritis. So that's a non-specific. Is that clear, folks? So that's that, okay? The rheumatoid arthritis is anti-CCP. Symptom, pain, swelling, underlying. Morning stiffness lasting for more than an hour, improve with use. This is completely opposite to osteoarthritis. Osteoarthritis people don't complain in the morning, they complain in the evening. These people, they complain in the morning, but they don't complain in the evening. Why? They feel better as they started moving. Is that clear, folks? That's why if you see rheumatoid arthritis people, they will never sit in one place, because if they sit in one place, it hurts. So they have to do things. They will clean the same garage multiple times. Okay. So the idea is because they have to keep doing something for their joint, folks. Okay. That's the idea. The next, since it's a systemic disease, it's symmetrical joint involvement. So they will involve right and left side at the same time because it's a systemic disease. They're going to have all the systemic symptoms, fever and everything, folks. You see? They're going to have that fever, fatigue, and all the systemic symptoms. Now, if you see, Erosions can happen. Juxta-articular osteopenia, soft tissue damage. Now, let's not read things that's common for both. If you see here, deformities, type this or underline. When it comes to rheumatoid arthritis, they always have cervical subluxation. See, you have cervical bone, thoracic, lumbar, sacral vertebrae. Rheumatoid arthritis always involves cervical. They asked that in the exam. What is subluxation? It's a partial dislocation, folks, okay? If I use the word dislocation, that's 100% dislocated. But if I see only a little bit, then we call it subluxation. And these people have ulnar finger deviation, which causes involvement of MCP and PIP. So this is where the ulnar deviation, the hand turns like this, right? If you see the x-rays, it will turn. In order to turn, they have to involve MCP joint. That's the only way you could turn it, folks, okay? Ulnar deviation, folks, okay? You could see a picture here. Maybe not this one properly, but that's ulnar deviation, folks, okay? Look at this. It goes in kind of this. This is ulnar, this is radius, okay? That's how you want to keep it. So ulnar, and also remember, this involves MCP and PIP, no DIP here. So that's a differentiating factor. So that's your osteoarthritis and rheumatoid arthritis. Let's take a look at the treatment. For osteoarthritis, activity modification, acetaminophen, NSAID, and some steroid. You could ask me, why do we have to give a steroid if there's no inflammation? Even though there's no inflammation, steroid still has analgesic part. It can help you with the pain. That's why we give it first. Is that clear? That's not a cure. It's a palliative. Every 6 months, they have to get the steroid shot off frequently. Okay, it's a symptomatic treatment. Now, when you go to rheumatoid arthritis, similar, but we add more medicine, disease-modifying agents, methotrexate, sulfasalazine, biologic agents, TNF-alpha inhibitors and stuff. What do we have to do before we prescribe TNF-alpha? PPD test must be done. Remember, you are inhibiting TNF-alpha. Okay, so all these are features to differentiate osteoarthritis and rheumatoid arthritis. Now, if you see, there are some extra articular manifestation. That means it happens outside the joint. So there's something called rheumatoid nodules in this tissue. And when patient has rheumatoid arthritis and pneumoconiosis of the lungs together, it's like a package. We get Kaplan syndrome. We talked about this in pneumoconiosis also, folks, okay? It's just putting two diseases. It's like how we call in GI Turcotte syndrome. You have a GI tumor and a brain tumor together, isn't it, folks? Same thing here. They're adding two diseases, folks, okay? When they have this disease with neutropenia and splenomegaly, we call it Felty syndrome. That's all it is. The most important I would highlight, carpal tunnel syndrome associated with rheumatoid arthritis. Rheumatoid arthritis causes carpal tunnel syndrome. I will explain when we do carpal tunnel, but you should know that. Okay. Maybe we could write it here so you understand better. In rheumatoid arthritis, your carpal tunnel bone. How many carpal bones are there? Nobody wants to look at me now. How many bones? Counting? Why don't you take an X-ray so you could see it? It's 8 carpal bones, 4 on the first layer and 4 on the second layer, right? All those 8 bones fuse together. It all stick to as one piece in rheumatoid arthritis. Now you should be wondering what to do with that and carpal tunnel syndrome. What is the definition of carpal tunnel syndrome? Anything that compresses the median nerve, we call it carpal tunnel syndrome, right? When the carpal bone fuses together, it's kind of compress the median nerve. Is that clear, folks? So I will repeat this again when we do median nerve, but that's carpal tunnel fibrosis. When you take an X-ray of this guy's hand, there is no way you could differentiate. Like all 8 bones will look like they all fuse to each other. Does that make sense, folks? That's what we call carpal bone fibrosis, okay? So these are all that. You guys review, pull up some questions.
Roy, right before you prescribe methotrexate, you should do like a CBC.
Why do you want to do CBC?
And like the liver enzymes.
No, I mean, so because you are thinking about the methotrexate side effect, or you're worried methotrexate will increase?
I mean, personally, I went through something with my mom. She had liver hepatitis B, but we didn't know she had hepatitis B, and she was prescribed recently. Well, when she was alive, methotrexate, and then weeks later, you know, like she started having jaundice and all these issues, and she was hospitalized, and they were like, "Well, mom, take like she has like active hepatitis B infection." Like, and then I was like, she took methotrexate, and we didn't know that she had, you know, hepatitis B. You know, it
How did you guys
completely,
not know when she had hepatitis B?
it was chronic and like it was like, so
So
it
there
wasn't
is
acute, it was
no
chronic.
history noted on her medical chart that she had hepatitis.
When we moved to the Middle East, like, so she was in the States, right? And they told her that she had hepatitis B, but she shouldn't worry because I think it was inactive. And then maybe like once she took the methotrexate, I don't know what happened honestly, but she was hospitalized and she had liver cirrhosis, and she took methotrexate before that week, and then she was hospitalized, and she was like, "Yeah, your mom has chronic hepatitis B infection." Is giving methotrexate. So it was a lesson learned, you know, to always do a liver
Well, but
just
this is what it is. You see, the problem started with proper history. Here, the failure of documentation hepatitis B is the number one problem. Okay. Now, if a doctor knows that the patient has a hepatitis B, of course, they will do all the tests, not only liver, but they will make sure if this medication can be handled, right? But it is it's not acceptable to have a hospital and not to have a documented hepatitis B. You see, that happens in certain countries, including my country, it happens. But the beauty here, that's the other part. Of course, if you have a history of hepatitis B, you must do a thorough liver function test before the medication. But we wouldn't worry about liver function test randomly a healthy person to prescribe methotrexate. But, the way you want to think, every human in the United States supposed to do liver function test, lipid panel, everything every year during their routine physical exam. Like, for example, if I have to start methotrexate, let's say today, I did my blood work a few months back. They have their liver enzyme right there. So they would know whether I should take it or not. Does that make sense? It's very less chance for me to increase liver enzymes since my last liver test, right? But it's either how the protocol is happening, but if I have a patient, let's say we have to give it methotrexate, but he has a systemic disease and he hasn't done blood work, I would do a blood work first. So that's what the problem, the documentation, these are the things but if you have a history, absolutely. All right. So now let's question. Let me pull those questions. So. All right, go for it. I want the diagnosis, okay. So when you see here, the diagnosis should be achondroplasia. Did we get the diagnosis? Okay, so if you think achondroplasia, 24-year-old woman comes at 12-week gestation for prenatal counseling. She's very short. You could see physical examination also significant depression of the nasal bridge and bulging forehead. Her husband is phenotypically normal, so which means she has 50% chance of getting it or not. Okay, so but they're asking an abnormality involving which of the following cell is most likely responsible for this patient feature. The patient has achondroplasia, which is a defect of endochondrial ossification. That's chondrocytes. Are we clear here, folks? That's the answer. Anything comes closer? No, nothing else comes closer. That's the achondroplasia features. Are we clear, folks? All right. Look at that. You guys better get that right. Don't jump and answer C, read it properly. They could be checking primary hyperparathyroidism. What is the diagnosis? What does this patient has? 70-year-old driving on a pothole, and now she has a pain on a tenderness over the vertebrae. That's a physical exam on the back. We feel it for vertebral compression fracture. She has a vertebral fracture, 70-year-old. So this is osteoporosis. Is that clear, folks? Do everybody has the diagnosis? Once you have osteoporosis, then you could go for C because that's normal. Now, the reason I say that don't jump it because I know we get excited because you know here you are doing osteoporosis question, but what is it mixed block if they ask primary hyperparathyroidism, right? So that's why I want you guys to be careful. Which one is primary hyperparathyroidism in here? What letter? Type the letter. I want everybody to answer. Which one is secondary hyperparathyroidism? Secondary hyperparathyroidism. That means you have increased PTH, decreased calcium. A, okay. What is this one? E. How do you read? Increased calcium, low PTH. That's exogenous intake of calcium or vitamin D toxicity, whatever it is, right? What is D? That's primary hypoparathyroidism. Is that clear, folks? Everything is gone. Good job. All right. You see, they added this question in 2023 because it's keep coming on the step one recently. Okay. That's the idea. They had the same question with a different thing, but they just changed the option to a chart instead of these things. Okay. You could see that. All right. Very good. So that's that. Diagnosis. What's the diagnosis? Without diagnosis, you guys are driving in dark. A 60-year-old man comes to the office due to a 4-month history of increasing mid-thoracic back pain, which is aggravated by coughing. The patient has also had thigh pain, but no weakness or numbness. Okay. No bladder bowel incontinence. Vital signs normal. On examination, there's a tenderness over the 8th and 9th thoracic vertebrae. Neurological exam is normal. The prostate is normal. Imaging studies reveals enlarged vertebral bodies with cortical thickening. This is a key. If you think osteoporosis, it should be cortical thinning. Okay. So it's cortical thickening. Serum testing for which of the following would be most helpful to establish? This is Paget's disease of the bone. Okay. Don't fall for osteoporosis. It is Paget's disease of the bone. I know you guys think because of the tenderness over the vertebral bone, but that's why they say the vertebral bodies with cortical thickening. They are giving the hint to tell it's not osteoporosis. Okay. So if you think it's Paget's disease, what do you want to look at it here? I know in the book we didn't cover when it comes to Paget's disease. The only thing is elevated is ALP, alkaline phosphatase, nothing else, no calcium, no phosphate, folks, okay? So only disease that elevated ALP is just Paget's disease because ALP is released from the bone and the liver. Those are the two places you guys get. But if it is the liver, they will have other liver enzymes elevated with it.
How could you tell the difference between I was stuck between osteopetrosis and Paget's disease because they both have bone thickening.
Yeah, but remember, osteopetrosis has pancytopenia, so you have to have all the cells low. They have to mention those things. Okay. And even let's say when I go with your diagnosis, do you have an answer for that here? There's no option in there, right? So that, but always pancytopenia, and remember that. And also extramedullary hematopoiesis, so they should have splenomegaly too, technically. All right, so that's that. This is again a Paget's disease, folks. Okay. Again, Paget disease, everything is normal except ALP. Okay. Same explanation here. Same explanation as previous question. 67-year-old man comes to the office due to slowly worsening pain in both legs. He has no trauma, fever, chills. The pain is deep and aching, is present throughout the day and increases with weight bearing. Examination shows bilateral bowing of the legs with palpable warmth over the anterior shin, but no redness. Imaging studies reveals bone expansion, cortical and trabecular thickening. You see that, folks? So that's Paget's disease, okay? First, I want you guys to identify what's abnormal here. Tell me where the problem is. You could use the site. Let's say, for example, this is the right side of the patient. This is the left side of the patient. Where is the pathology? Everybody's typing right femoral head. The site is right, but it is not a femoral head. I don't like the word of head. The actually neck is missing here. You have neck here. Do you see that? So you have a head, you have a neck, and we call this is a greater trochanter and lesser trochanter. That's the name of the bone. In this picture, I see the head, I see the trochanter, but I don't see the neck. This is a femoral neck fracture. Is that clear, folks? Okay, good. If you think it's a femoral neck fracture, now you should know the answer. That's your medial circumflex. We just talked about it. Look at that tiny artery, guys. It's unbelievable, right? How much blood can supply for the head of the femur from that. That's that. Okay. All good? You see the options, okay? I'm not going to give you option. We want to diagnose. Go ahead. A 62-year-old woman comes to the office due to activity-related joint pain and hands and periodic morning stiffness for 10-15 minutes. The minute you see that, you should know the diagnosis, because if you think it's rheumatoid arthritis, it should be more than an hour. This is less than an hour. That's osteoarthritis, okay? That's important. Early morning stiffness, more than an hour. The pain is moderately severe and has begun to limit her activities. Okay, you could see. What else do you see? You only see PIP and DIP here. Okay, PIP and DIP, they are not even showing there. And they are telling that physical exam shows foam nodules over the DIP bilaterally. Now remember, you could ask me, what about PIP? We should know DIP is not involved in rheumatoid arthritis. Is that clear, folks? So at least you could get. That's osteoarthritis. Is everybody clear? Okay. Okay, perfect. Go for it. That should give you the diagnosis, isn't it? Okay. And wrist and joint bilaterally, symmetrical. So that's basically rheumatoid arthritis. They're asking which of the following is the most specific. Okay, you should be fighting between two things, folks. B and D, but B is the most specific one. Remember that? That's exactly what it is. Okay, that's a rheumatic factor. Look at that, 52% and 34. That's a non-specific. Okay. It's a diagnosis. Asymmetrical joint. Worsen by the end of the day. So that should be osteoarthritis, isn't it? You guys see the patterning, folks. If you think is, so let's say you know it's osteoarthritis, but you don't know what is these options are, right? Like some of them, you could still rule out calcium pyrophosphate, that's pseudogout. IME deposition, that's hemochromatosis part and stuff, okay? Synovial cell hyperplasia, that's rheumatoid. Virus induced, that's a septic arthritis. So that brings you to fissuring, flaking of articular cartilage. Even if you don't know what is B, you could still rule out the other options here, folks, okay? Fissuring and flaking articular cartilage is basically how they are getting destroyed. You could see pieces by pieces. That's what it is. All right.
Dr. Wright,
Yeah.
what part is said, like I didn't understand, like what is cryptation on flexion and extension? What does that mean?
Which one? Where do you see?
Cryptation, you know how it says cryptation?
Are you? I can't hear you. It's not clear what you're saying.
So you know how it says cryptation on flexion and
Oh,
extension?
crepitation is sound. These osteoarthritis people, when they walk, you hear a little click in their joint. That's what crepitation means. It's producing a sound. They will like a little tick. They will produce every time they walk.
Okay.
Yeah. What's the diagnosis by looking at this? You see here, it's all deviated, right? Ulnar deviation, I see. That's a rheumatoid arthritis. What's the answer?
Dr. Roy, could you remind us where ulnar is?
Towards your body. This is radius.
On the side of the pinky.
Yeah, this is the ulnar, not ulnar bone, the one here. So rheumatoid arthritis associated with cervical spine, subluxation. We talked about it, right? Okay. So that's that. 62-year-old woman comes to the office due to 3-month history of painful swollen wrist and knees, also has joint stiffness, which is upon waking. Review of system is positive for fatigue. So she has a lot of systemic symptoms. The patient's only other medical condition is hypothyroidism. Why are they bringing that? That's also autoimmune disease, okay? So they're trying to say one autoimmune, so you could think the other one. So it's a rheumatoid arthritis, basically this patient has it, folks, okay? Now, if you think it's a rheumatoid arthritis, which one is this? I know it's not in the book, but we should be able to come up with it. If you're giving TNF-alpha inhibitor, so that means it should be associated with it, isn't it? The treatment is TNF-alpha inhibitor. So you should write it down next to rheumatoid arthritis on your first aid book. IL-1 and TNF-alpha is involved in that. IL-1 and TNF-alpha. All clear, folks?
Dr. Roy,
Uh-huh.
if the question were to ask something along the lines of what would essentially inhibit the pathogenesis, because I know there's a similar question in like ulcerative colitis or Crohn's, would it be for number D? Would it be the letter D? Because interleukin-10 and TGF-beta, they're anti-inflammatories.
Uh-huh.
Naturally, in RA, you kind of have where sometimes it's more active, sometimes it's less active.
But
So
the problem with the synovial inflammation, we don't know if D will help actually.
okay.
Because mostly anti-inflammatory, it's in the blood is much better than getting into a synovial fluid.
So you probably won't ask that question ever, right? Only keep it to IBDs. Okay, thank you.
All right.
Dr. Roy, but number 2, is it 928 or 982?
982.
Yeah.
All right. Take a break. We'll see you guys soon.